participants who have joined from various parts of India and abroad. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our chief guest, Dr. Mamta Manglani, keynote speaker, Dr. Shruti Kakkar, all discussants and participants to this virtual symposium on emerging complications in thalassemia. Before we commence the proceedings, I would like to welcome and introduce the convener for this webinar, which is being organized under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a senior consultant hematologist and BMT expert practicing at Surat, Gujarat. I request him to navigate this program further. Over to you, Dr. Amit.
Thank you so much. Good morning, one and all, and good afternoon and good evening for those who are joining from rest part of the world. Today, our guest speaker is Dr. Shruti Kakkar from Ludhiana. She's going to lecture us on emerging complications in thalassemia. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus and managed by Perfect Square. I thank Mr. Ashish Kumar and Team Zydus, Mr. Yash, Mr. Kalpesh and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Mamta Manglani from Mumbai, our guest speaker for the day, Dr. Shruti Kakkar from Ludhiana, all our discussants who are themselves eminent hematologists, and you participants for sparing your Sunday morning, afternoon, or evening. Now it's a time to introduce all our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Abhilasha Sampagar from JNMC Belgavi, Dr. Akshay Mandloy from Suraksha Diagnostics, Kolkata, Dr. Amit Jain from Pediatric Hematology, Oncology and BMT Center, Mumbai, Dr. Anil Sharma from Apollo Medics Super Speciality Hospitals, Lucknow, Dr. Anshul Gupta from SGPGI, Lucknow, Dr. Arpita Gupta from LTMG Hospital, Sain, Mumbai, Lieutenant Colonel Dr. Ashok Meshram from INHS Aswini, Kolaba, Mumbai, Dr. Gopinathan M from SGPGI, Lucknow, Dr. Gunjan Prasad from Apollo Clinicals Hospital, Kolkata, Dr. Hamsa Yusuf Dalal from Fortis Hospital, Mulund, Mumbai, Dr. Jagdish Chandra from ESI Hospital, New Delhi, Dr. Kunal Goyal from Tata Memorial Hospital, Actrack, Mumbai, Dr. Nidhi Dixit from Apollo Hospitals, Kolkata, Dr. Neeta Radhakrishnan from Postgraduate Institute of Child Health, Noida, Dr. Omkar Khankar, Consultant Pediatric Hematologist Oncologist from Bombay Hospital Institute of Medical Sciences and Assistant Professor at Department of Pediatric Hematology Oncology at TN Medical College and BYL Nair Charitable Hospital, Mumbai, Dr. Pranata Kini from MCGM Comprehensive Thalassemia Care, Borivali, Mumbai, Dr. Prashant Bhatt from KMC Hospital, Mangaluru, Dr. Priyanka Agarwal from Banaras Hindu University, Varanasi, Dr. Prasanta Kumar Chaudhary, Consultant in Hemoglobinopathy, Dr. Purva Kanvinde from BJ Wadia Hospital for Children, Mumbai, Dr. Rajat Bhattacharya from KK Women's and Children's Hospital, Singapore, Dr. Ruchira Mishra from SRCC Children's Hospital, Mumbai, Dr. Santanu Sen from Kokilaben Dhirubhai Ambani Hospital, Mumbai, Dr. Shailendra Prasad Verma from King George Medical University, Lucknow, Dr. Sujata Sarma from Lokmanya Tilak Municipal Medical College and Hospital, Sain, Mumbai, Dr. Suma T.L. from SCG Hospital, Bengaluru, Dr. Sundar Shivale from Tata Medical Center, Kolkata, Dr. Urmimala Bhattacharji from PGI, Chandigarh. Now it's a time to introduce our special guest for the day, Professor Dr. Mamta Manglani. Mamta Manglani ma'am requires no introduction, but it's my formal duty to introduce her. She's a director, academic and research at MCGN Comprehensive Thalassemia Care, Pediatric Hematology, Oncology and BMT Center, Borivali, Mumbai. She was a former director at the above institute from 1-2-2017 to 6-7-2022, former professor and head chief division of hematology, oncology and program director, Pediatric Center for Excellence for HIV Care, Department of Pediatrics at LTMM College and General Hospital, Sain, Mumbai. She started the first public sector BMT unit in the country at LTMM College and General Hospital, as well as an 8-bedded unit at the Borivali Center. She received 8 Oration Awards and 19 awards for research papers. She obtained her training in pediatric hematology oncology at Robert Wood Johnson University of Medicine and Dentistry, New Jersey, USA in the year 1997. She also received the Fogarty Fellowship in Pediatric HIV at New York University, USA in 2004. She is a chairperson at Pediatric Hematology Oncology Chapter of IAP from 2018 to 2020. She has over 554 presentations at local, regional, and national and international conferences, and about 184 publications in various journals. It's my privilege and to invite her to inaugurate our webinar and give some words of wisdom. Over to you, Professor Mamta Manglani, ma'am.
Thank you, Amit, for such a lovely introduction. At the outset, I would like to thank the Mumbai Hematology Group, especially Professor Agarwal sir, for inviting me as a chief guest here today to inaugurate this webinar. So, respected sir, President MHG, Dr. Rucha Patil, Honorable Secretary MHG, Dr. Shruti Kakkar, today's guest speaker, Dr. Amit Khurana, the anchor, Dr. Sumit, all dignitaries present here, and dear friends. I congratulate sir for his perpetuity in imparting science to all of us continuously for many, many years now. In fact, I thank sir for giving me this honor today, especially during a webinar which is on thalassemia, a subject very close to my heart. However, we shall hear about this subject from our eminent speaker in some time, and I would not dwell on it. When I look back at my own journey, I often feel that we are sometimes driven by, chosen as an instrument by the Lord, by nature, to do some work. And that something is instilled into us as a passion, I think. Whether we call this destiny or a passion which drives us to our destiny, I'm not very sure. Nevertheless, as is said, there is no elevator to success, and one has to take the stairs to success. And therefore, hard work is integral to success of any kind. Each one of us, however, is endowed with that capacity to work hard. And here I wish to quote Dr. Yvonne Thornton, who in a speech at Tuskegee University in 2003, during a graduation ceremony for students said, and I quote, "Whether you go into research, business, law, medicine, public service, or education, neither you nor society can continue to survive or prosper simply by implementing what is already known. Somebody is going to have to come up with meaningful new ideas, creative new approaches, and important new discoveries. Why can't that somebody be you?" I unquote. But for that, one must dream a big dream. And on that note, I would like to mention a quote by Honorable APJ Abdul Kalam ji, our former president, who said, "A dream is not what you see while sleeping. It is something that does not let you sleep." I'm sure many of you young colleagues have such dreams and would fulfill them in the near future. Of course, patients have to be at the core of our heart, and providing quality care should be our major passion, even in the public sector, where we do not probably get financially compensated for the work we do. Thanks to the great support I had from my colleagues and authorities in the Bombay Municipal Corporation, that we began the first ever BMT center, though one-bedded, at Sion Hospital first, and later an 8-bedded center at the Borivali center that we are presently working at. These are both for pediatric BMTs. And I can proudly state here that our team has completed more than 250 transplants at the Borivali Center at no cost or nominal cost to the patients' families. Besides, the comprehensive thalassemia care offered at our Borivali Center has given a lease of quality life to many a thalassemia patient. I'm sure there are many of us who are passionate to innovate and achieve great milestones in the journey of our careers. I wish all the best to all the young colleagues and friends who are participating today for the same, to achieve great heights in their career in the future. Where there's a will, there's a way. This has worked for us. It works for everyone. With these few words, I conclude my remarks and wish the webinar all the best. I declare the webinar open. Thank you very much again.
Thank you so much, ma'am, for the great words of wisdom. It's always a pleasure to hear to you, ma'am. I now invite our president and the quiz master for the day, Professor Dr. Agarwal sir, for the hematology quiz. and the weekly case discussion.
Thank you, Amit. And thanks to Professor Mamta Manglani for inaugurating this webinar. So the first half of this webinar, we have the beginning with Sunday quiz as usual. So today's quiz is related to hemochromatosis. You will be given 10 statements about hemochromatosis. Out of these, one is false. You have to pick up the false statement and email its number to mbagarwal1@gmail.com. As usual, we will announce all the names in the order in which we receive the correct replies, and then the winner. And the winner will be fastest finger first. And here are the 10 statements regarding hemochromatosis. These are their numbers, and one of the statement is wrong. You pick up the number of that wrong statement and email it to mbagarwal1@gmail.com. 1. It comprises a group of inherited disorders causing iron overload. 2. It's a result of failure of hepcidin response to increasing iron stores. 3. It also results from transfusion dependent and non-transfusion dependent anemic disorders, that is thalassemia and myelodysplastic syndromes. 4. The most common symptom is fatigue. 5. The most common clinical manifestations are liver disease and arthritis. 6. It causes increased risk of infection with Vibrio vulnificus. 7. MCV is often elevated above 94 FL. 8. It is characterized by increased transferrin saturation, which precedes increased ferritin. 9. Dietary restrictions of iron offers no proven benefit. And 10. Besides hepatocellular carcinoma, there is increased risk of breast and colorectal cancer. So these are the 10 statements. One of these statements is wrong. 9 are correct. The wrong statement, its number, you have to email to mbagarwal1@gmail.com. And I'm going to keep this slide on for a few seconds. Okay, so pick up the false statement, email its number to mbagarwal1@gmail.com. Winner, fastest finger first. We are going to tell you the winner and those who send the correct reply after Dr. Shruti's lecture and before we go to the Q&A session with her. The second part this morning is our weekly hematology, and this time it is not case, it is cases. What we are going to do is to show you certain cases of inherited bone marrow failure syndromes presenting later in life to an adult hematologist. And this is going to be a group of 8 cases. So IBMFS are a group of genetic disorders. There is inadequate production of one or more blood cell lineage. Often there are birth defects or disease in other organs. There is predisposition to malignancies, both MDS, AML, and solid tumors. Usually, these disorders are managed by pediatricians. However, increasingly, more and more patients are seen by adult hematologists. There are diagnostic and therapeutic challenges. prompt diagnosis of IBMFS in adults is important. Timely diagnosis ensures optimal therapy and minimizes the treatment-related toxicity. In addition, it facilitates genetic counseling and cancer surveillance for the extended family. The hematological manifestations of this group of disorders include pancytopenia or red cell aplasia or thrombocytopenia or neutropenia or monocytopenia and lymphopenia. The disorders that this group include, and there can be many more, Fanconi's anemia, dyskeratosis congenita, Diamond-Blackfan anemia, thrombocytopenia absent red-eye syndrome, severe congenital neutropenia, Schwachman-Diamond syndrome, congenital amegakaryocytic thrombocytopenia, familial platelet disorder with propensity to AML, monomac and related GATA2 deficiency disorders. There is another way to look at these disorders, and that is by looking at the pathway which is disrupted. These could be DNA repair, telomere maintenance, ribosome biogenesis, mRNA processing and export, protein folding and trafficking, ribosome maturation, growth factor receptor signaling, and transcriptional regulation. Our first case and the second case and the third case belong to the group of Fanconi's anemia. The first case, a 25-year-old woman from Mumbai, having fatigue for a few months, found to have pancytopenia. Marrow showed there is MDS with monosomy 7 and trisomy 1q. An allotransplant was planned. However, she had tan complexion, small chin, and high-pitched voice. In view of her young age and these findings, patient was screened for Fanconi's anemia. The DEB chromosome fragility test of peripheral blood leukocyte was abnormal, which established the diagnosis of FA. Accordingly, her pre-transplant conditioning regimen was modified to minimize the toxicity from full-dose alkylating agents such as cyclophosphamide. That's our first case, presenting at the age of 25. And the learning point from this case is that the physical manifestations of IBMFS may be very subtle. The second case is a 22-year-old male from Porbandar, was diagnosed with severe aplastic anemia. He had no history of birth defects. Height and weight were average for his age. His only sibling, younger sister aged 19 years, was found to be an HLA match. However, this sibling of his was short in stature and had congenital hearing loss. Her blood counts were normal, but her DEB chromosome fragility test established the diagnosis of Fanconi's anemia in both. Sister was declared as an inappropriate donor. A search for an unrelated donor was initiated. And what was the learning point from this case? The phenotype of FA may vary even within a single family. And this variability is due to incomplete penetrance or variable expressivity of pathogenic mutation in a family. The third case of Fanconi's anemia is once again an adult 23-year-old man from Bijapur who developed a tongue ulcer. He was otherwise healthy. Biopsy showed squamous cell carcinoma. The human papilloma virus and P16 testing on the biopsy specimen were negative. There was no history of tobacco, gutka chewing, or smoking. He had no obvious congenital anomalies. His blood counts and family history were unremarkable. Partial glossectomy and neck dissection were performed. Recognizing the increased incidence of tongue cancer in a young adult with Fanconi's anemia, the astute oncologist ordered for DEB chromosomal fragility test. The test was borderline abnormal. Subsequently, DEB testing on skin fibroblast was overtly abnormal, establishing the diagnosis of FA with somatic cell mosaicism. In view of this diagnosis, adjuvant radiation and chemotherapy were considered contraindicated. The learning point from this case was certain cancers are distinctly characteristic of IBMFS. A few words about Fanconi's anemia. It's a heterogeneous disorder, both genetically and phenotypically. It has three manifestations: marrow failure, birth defects, and they can be absent in 25 to 40% of patients, and predisposition to cancer, both hematological and solid tumors. Left upper part, you see the caffeolate spots and the hypopigmented spots. On the right upper, you see the abnormal hand. At the bottom, you see the aplastic marrow. And these are the percentage of various anomalies you find in Fanconi's anemia. From highest to lowest prevalence: pigmentation of skin, short stature, upper limb abnormality, testicular, eyes, kidney, head, developmental disabilities, low birth weight, hearing loss, heart and lung, and GI tract, from 60% to 5%. The hematology of FA is that there is a marrow failure. However, the hematological manifestations vary. Thrombocytopenia and macrocytosis precede anemia and neutropenia. The median age of hematological abnormality is 7 years. The marrow failure is progressive. Over 50% present with just isolated thrombocytopenia, which slowly progresses to pancytopenia in 4 years. The cumulative incidence of marrow failure by the age of 40 is 50 to 90%. In some patients, hematological abnormalities may never become clinically evident. The risk of leukemia is 500-fold more. The risk of solid cancer is 50 times more. By the age of 40, MDS, AML, and solid tumors occur in 30%, 10%, and 30% respectively. Those having mild marrow failure live longer and have the highest risk of cancer. The commonest solid tumors include squamous cell carcinoma of head and neck, esophagus, vulva, and anus. There's also an increased incidence of hepatocellular adenoma and carcinoma in about 3%. The biochemical defect is impaired DNA repair. There are over 16 different DNA repair genes which are linked. Inheritance is autosomal recessive and rarely X-linked when the gene in FANCB is involved. The cells exhibit a low tolerance for DNA damage, both in vitro and in vivo. Accordingly, chemotherapy and radiation therapy must be administered at reduced doses or avoided altogether. The diagnostic tests are based on hypersensitivity to a DNA cross-linking agent, and there are two of them, DEB or mitomycin C. DEB or mitomycin C treated lymphocytes demonstrate a significant increase in chromosomal breaks over the normal control. These tests are highly sensitive and, with rare exceptions, specific for Fanconi's. Chromosomal fragility testing of fibroblasts should be considered in those patients with clinical and genetic suspicion of FA, but having negative DEB or mitomycin C test. Regarding management, FA with mild hematological manifestations, you just monitor the blood counts and do intermittent marrow examination for development of MDS. The plan should be made for transplant because hematological complications can develop very rapidly. Given the inherent sensitivity of patients of FA to radiation chemotherapy, RIG transplants are employed. Androgen therapy is effective in 50 to 80% of patients. However, this therapy is associated with significant side effects, including increased risk of hepatocellular carcinoma. Close surveillance for development of malignancies is needed. Surveillance for head and neck cancer every 6 months and regular gynae checkup for early vulval cancer. Our fourth case is that of dyskeratosis congenita. And the cartoon on the right side gives you a summary of what happens in this disease. So a patient is an 18-year-old man from Nashik who was seen by urologists for multiple recurrent urethral strictures. When he presented to the one in Mumbai, his pre-op CBC showed low platelets, and hence hematologist was consulted. Hematologist noticed that besides thrombocytopenia, there was nail dystrophy. Bone marrow biopsy showed hypocellularity, and this led to the investigations which showed telomere length analysis being shortened. A diagnosis of DC was made. No pathological mutation was detected in any one of the known DC genes. Patient later on developed AVN of the hip, which is another known complication of DC. The learning point from this patient was an acquired non-neoplastic disorder affecting extramedullary tissue, such as nail dystrophy, urethral stricture, and AVN may be the first manifestations of an IBMFS. The presence of short telomeres in circulating blood cell is hallmark of DC. Like Fanconi's anemia, DC is also a cancer predisposition syndrome, and cancer is the third leading cause of death in these subjects after bone marrow failure and pulmonary fibrosis. Malignancies in DC usually develop in third decade of life and therefore are diagnosed in milder forms of the disease. By 50 years, the cumulative incidence of malignancy is 25%. The most common solid tumors are squamous cell carcinoma of head and neck, and also cancers of GI tract and female genital tract. By 50 years, the cumulative incidence of MDS and AML is 30% and 10%. DC should be considered as a differential diagnosis of young adults with MDS or MDS-AML. It's a phenotypically heterogeneous disorder caused by defect in telomere maintenance. Telomeres are DNA structures that protect chromosomal ends. Human telomere DNA is synthesized by the enzyme telomerase. And this telomerase has two components, the TERT and the TERK, the reverse transcriptase and the RNA molecule. Most somatic cells lack telomerase, and therefore telomeres shorten with each cell division. There are 9 genes responsible for DC. DC has a clinical diagnostic triad of reticular skin pigmentation, nail dystrophy, and mucosal leukoplakia. The other clinical manifestations include marrow failure, which occurs in 50% by the age of 50 years, and pulmonary fibrosis as well as liver cirrhosis are the other frequent complications. However, MDS, MDS-AML, and extramedullary complications could be the initial manifestations. In a classical case, mucocutaneous features appear in childhood, marrow failure develops in adolescence, and death occurs by young adults. This is the nail dystrophy, oral leukoplakia, hypopigmentation, which is more pronounced in sun-damaged skin of the neck, as shown by the white arrow, and the typical reticular rash, which is better appreciated in this. Pulmonary fibrosis, which is more appreciated in the CT scan. And this once again gives you the relative prevalence of clinical features of patients of classical DC from mucocutaneous to gonadal in the descending prevalence. Mucocutaneous eye abnormality, pulmonary fibrosis, developmental delay, teeth, early graying, liver fibrosis, short stature, malignancy, urethral stricture, cerebellar, and gonadal abnormalities. One should not make diagnosis of DC solely on the basis of shortened telomeres. Shortened telomere length is a sensitive but non-specific finding for DC. It occurs in 30% of patients where BMF is due to other causes. Similarly, in the absence of BMF, decreased telomere length does not identify mutation carriers. DC has different mode of inheritance. The most common form is X-linked due to mutations in the DKC1 gene. Autosomal dominant forms are caused by mutations in the TERK or TERT genes. Patients with pulmonary fibrosis and a macrocytic anemia or aplastic anemia in the family should be examined for the TERK and TERT mutations. Autosomal recessive forms of DC are caused by biallelic mutation in the other genes involved in telomere maintenance, including these which are shown here. In 50% of patients with classical constellation of findings, that is marrow failure, mucocutaneous features, and short telomeres, none of the known DC genes are mutated, suggesting that additional causal genes will be discovered in the coming years. The treatment of DC is very much like that of FA. Those with mild hematological manifestations are monitored with their blood counts and serial bone marrow examination for development of MDS. Smoking should be avoided, and the drugs that lead to pulmonary damage should be avoided. Androgen therapy is useful to improve the marrow function. Shielding of lungs during radiotherapy. Plans for a reduced intensity transplant. Transplant-related morbidity and mortality is highest in DC than any other IBMFS. This is because of pulmonary and vascular complications that set in. Lung transplant is an option. And surveillance for head and neck squamous cell carcinoma should be done on a regular basis. My next condition is Diamond-Blackfan anemia. So the case 5 is once again an adult 28-year-old healthy woman from Nagpur having normal stature. She gave birth to 2 children with Diamond-Blackfan anemia. The older child was transfusion dependent while the younger one was steroid responsive. The genetic testing demonstrated a heterozygous nonsense mutation in RPS19 in the proband as well as her affected children. Interestingly, woman had an MCV of 102 FF. And the learning point from this case is macrocytosis is often overlooked as a clue to the diagnosis of IBMFS and may occasionally be the sole manifestation. DBA is genetically and phenotypically heterogeneous condition. It is associated with reduced or absent erythroid precursors in the marrow. Macrocytic anemia and reticulocytopenia are other major diagnostic criteria. In some individuals of DBA, anemia is transient. Rarely, the red cell aplasia may progress to aplastic anemia in DBA. The elevated levels of erythrocyte ADA, and that is seen in 85% of patients. The diagnosis of DBA is usually made under the age of 1 year. But as in our proband, occasionally the condition may be diagnosed in older children or even adults. In half of the patients, there are associated congenital anomalies or growth retardation. The common birth defects include thumb abnormalities, midline facial defects, and congenital heart disease. In some individuals, like in our, the clinical manifestations may be very subtle. This is an abnormal thumb in an adult with RPL11 mutation causing DBA. And this is muscular ventricular septal defect. And you can note the blood flow across the defect. And that once again shows you the relative prevalence of clinical features of DBA from short stature to brain abnormalities, 30% to 5%, short stature, head, face, palate, upper limb, urogenital, cardiopulmonary, eyes, neck, and brain. DBA is a ribosomopathy. Genetic testing can provide a definite diagnosis in 60% of cases. Steroids are effective in normalizing hemoglobin in 65% of patients. How do the steroids work remains unclear. Blood transfusion is the mainstay of treatment for the rest. Leucine treatment lessens the degree of anemia. Bone marrow transplantation is curative in patients of DBA and must be offered to those who remain transfusion dependent or develop aplastic anemia. Patients with DBA are also predisposed to malignancy, including MDS, AML, and solid tumors. The median age of malignancy is 41 years. About 25% of patients achieve spontaneous hematological remission. And this usually happens within first 20 years of life, especially in those who are steroid responsive. Hematological relapses may occur during pregnancy or when estrogen-containing oral contraceptives are used. Deletion 5q syndrome, which is a condition affecting elderly females, and which is a type of myelodysplastic syndrome, shares several features with DBA, including macrocytic anemia and paucity of erythroid precursors in the marrow. My sixth case is that of TAR syndrome. Once again, an adult, 25-year-old female from Assam. She was a known case of TAR. She was transfusion independent so far, but now at the age of 24 becomes transfusion dependent with a severe macrocytic anemia and worsening of her thrombocytopenia. Marrow revealed MDS RAEB2, and there was an acquired cytogenetic abnormality in version 3.3. She received treatment with decitabine and then an unrelated donor transplant. The learning point from this patient was that IBMFS are associated with increased risk of late onset MDS. This is a characteristic radiology of thrombocytopenia with absent radial bone. Patients with TAR have usually bilateral defects in the development of radii together with severe thrombocytopenia at birth. Bone marrow aspirate shows decreased megakaryocytes. However, this is not required to make the diagnosis. During infancy, some of the patients may require repeated platelet transfusions to maintain the platelet count above 10,000. After the first year of life, platelet transfusion requirement diminishes. The extraskeletal manifestations include short stature, facial dysmorphism, cardiac defects, and genitourinary abnormalities. Orthopedic interventions dominate the treatment of TAR later in life. The development of aplastic anemia is not a common finding. However, acute myeloblastic leukemia and acute lymphoblastic leukemia have been reported albeit rarely. Present description that of a patient with TAR who developed MDS. TAR syndrome is a defect in messenger RNA processing and export. It is caused by compound inheritance of mutations affecting RBM8A gene and coding Y14, which is a RNA binding protein. My second last case is of severe congenital neutropenia. Again, an adult 18-year-old girl from Vadodara having SCN due to ELN missense mutation was referred to Mumbai for opinion regarding transplant. She was already diagnosed at the age of 3 months when she had presented to the local pediatrician with omphalitis and carbuncle. After the diagnosis was made, she was on daily injections of GCSF ever since then. She was undergoing annual marrow examinations, but there was no overt morphological or cytogenetic evidence of MDS. Gradually, her requirement of GCSF increased, especially during last few years. Her healthy brother was not an HLA match. In view of declining neutrophil response to GCSF and a great risk of progression to MDS AML, she was subjected to a match-unrelated donor transplant using a non-myeloablative conditioning regimen. The learning point in this patient was, and this is severe periodontal disease in a case of SCN. And the learning point was, there is a looming large risk of AML developing in such patients, and this has a significant bearing on clinical decision-making regarding transplant, and not only SCN, but almost all patients of IBMFS. SCN is genetically a heterogeneous group of disorder characterized by severe neutropenia almost at birth with ANC less than 200 cells per cubic millimeter. Marrow shows an arrest at the promyelocyte or myelocyte stage of neutrophil maturation. Bacterial infections such as omphalitis, skin abscesses, deep tissue abscesses, oral ulcers, and pneumonia develop in 90% of subjects by the age of 6 months. This has a poor prognosis, and death by overwhelming infections commonly occurs in the first 10 to 20 years of life. Despite GCSF, mortality due to infections remain the major concern, and there's 12% cumulative incidence of death by sepsis by 15 years of age. SCN is a defect of protein folding trafficking. It exhibits multiple patterns of inheritance, autosomal recessive, autosomal dominant, X-linked, and sporadic. Accordingly, mutations in several different genes have been shown to cause SCN, including the genes that are shown here. The X-linked gene WAS is also involved. The mutations in ELN, however, account for almost 60% of cases, and ELN encodes for the neutrophil elastage. Allotransplant is the only curative therapy. In the absence of MDS or MDS AML, the survival of patients with SCN who have undergone transplant from a HLA matched sibling is 90%. Widely accepted indications for transplant in patients of SCN include inadequate neutrophil response to GCSF and development of MDS or AML. The most vexing question is whether to perform transplant in patients who are doing well on GCSF. My last case is of Shortman-Diamond syndrome. A young girl aged 8 years from Nagpur was diagnosed to have SDS based on exocrine pancreatic insufficiency, short stature, and metaphyseal dysostosis. Subsequent genetic testing demonstrated biallelic mutation in SBDS. Over the ensuing years, her peripheral blood counts remained relatively stable with ANC around 1200, hemoglobin around 11, and platelet count around 80,000. At the age of 15 years, the marrow showed an acquired cytogenetic abnormality, and that was I7. However, there was no histological evidence of myelodysplasia. Subsequent marrow examination showed persistence of this benign clone over the next decade. At the age of 26 years, she even gave birth to a healthy child. And the learning point here is an acquired chromosomal abnormality in the hematopoietic progenitor does not portend a negative clinical outcome in all patients of IBMFS. SDS is a defect in ribosome maturation. It is characterized by exocrine pancreatic insufficiency, marrow dysfunction, including increased risk of MDS, AML, and skeletal abnormalities. Most cases are diagnosed in early childhood. 90% of patients have biallelic mutation in SBDS gene. The exocrine pancreatic deficiency can be confirmed by demonstrating low serum isoamylase, which is decreased in both children and adults with STS. Imaging of the pancreas will show you characteristic fatty pancreas. For unclear region, the pancreatic insufficiency improves with age in many patients. And by the age of 4 years, almost 50% of patients no longer require pancreatic enzyme supplements. This is an MRI showing fatty pancreas. Even with adequate pancreatic enzyme replacement, most patients with SDS remain below or at the 3rd percentile with respect to height. The skeletal manifestations in NDS include metaphyseal dysostosis, rib cage dysplasia, and osteoporosis. Spinal fractures are common in the adult age. This is one radiological metaphyseal dysostosis. And that's another one. Once again, the prevalence of clinical features in patients of SDS from highest to lowest include neutropenia in 80 to 100%, severe neutropenia in 30 to 60%, anemia, thrombocytopenia, exocrine pancreatic insufficiency in 85 to 100%, elevated transaminases, dysostosis in 40 to 100%, rib cage anomalies, and short stature. Intermittent or chronic neutropenia of varying severity is evident in almost all patients of SDS. Anemia, once again, with mild macrocytosis is present in 50% of cases. Thrombocytopenia is present in 50% of cases. Bone marrow examination shows hypoplasia. Patients of SDS can progress to severe aplastic anemia. 30% of patients can show clonal cytogenetic abnormalities such as I7, deletion 20, with or without MDS and AML. Sorry, without MDS and AML. Such hematological clones may persist for years and may not necessarily be harbingers of progressive marrow dysfunction. Indeed, neither I7 nor deletion 20 are associated with increased risk of MDS or MDS AML. The reported rate of transformation to MDS AML and in SDS patients ranges from 0 to 36%. Solid tumors are extremely rare in SDS. Allogenic transplant, the only cure for the hematological manifestations of SDS, is reserved for patients having severe cytopenia or developing MDS AML. A word about other IBMFS, and 3 of them I'm not discussing today. The congenital amegakaryocytic thrombocytopenia, familial platelet disorders with propensity to AML, and GATA2 haploinsufficiency disorders. I conclude my talk by saying that IBMFS phenotypically is a heterogeneous disorders. These are often associated with congenital anomalies and they should be looked for. There is a predisposition to malignancy, both hematological and solid tumors, and this should be looked for. The phenotypic variability, even within a single family, can sometimes be very striking. Many factors contribute to the incomplete penetrance and variable expressivity, including modifier genes and spontaneous gene conversion leading to somatic cell mosaicism. In some patients with hematological and the physical abnormalities could be very subtle or almost absent. These patients may come later in life with MDS AML or a characteristic solid tumor or a non-malignant condition affecting extramedullary organs like pulmonary fibrosis to a lung specialist, urethral structure to a urologist, and avascular necrosis to an orthopedician. Accordingly, adult hematologists must consider the diagnosis of IBMFS in those patients who manifest these features. Today, NGS-based diagnostic tools are becoming available and they are cost-effective. As a result of it, patients with atypical presentations of known bone marrow failure syndrome and novel bone marrow failure syndromes will be diagnosed more often in adults and adolescents. Well, thank you so much for giving me this opportunity to present these 8 cases to you. As we do have some time, if somebody would like to share some experiences, you're most welcome.
Sir, may I mention that MECOM genes are now increasingly being found to be associated with this new finding. They can present with MECOM mutation. Okay, they can present with a severe marrow failure syndrome, even at birth. I had recently one and 2 others, which just adds to the complexity. But I agree now with the NGS-based assay is becoming increasingly common to diagnose these conditions. And even adult pathologists have to be very careful. So all cytopenias, we think of inherited bone marrow failure syndrome unless proven otherwise. And all aplastic anemias use this for NGS-based. So these are very important things and people need to identify earlier.
Absolutely. And this presentation as MDS in young people, AML in young people, single line defects, macrocytosis, some subtle congenital abnormalities in the skin skeleton, etc., are something which adult hematologists have to be very careful. Pediatricians are very aware, but the adult hematologists, because you are biased that everything is acquired, but it isn't. Dr. Ruchira, you are muted. Some problem anyway. Anybody else?
Sir, just in cases when we are, working up these patients, sometimes they have very subtle morphological abnormalities, as you mentioned, maybe 1 or 2 cephalosports or maybe hypopigmented patch and pancytopenia at presentation. And when we go for NGS panel, it comes out to be, FANC mutation or something which is not mentioned in the literature, and they mention it as, mutation of unknown significance. So in those situations, it becomes very difficult, in which way we have to manage these cases, whether we should go for like acquired plastic anemia or inherited, inherited bone marrow failure syndrome. So we have 1 or 2 such patients where still we are not able to, although we have tried in both ways, but as we know that the responses sometimes may not be that good. So still it is a problem, sort of.
You are absolutely right. In fact, this presentation got precipitated because of a patient that we just saw at the age of 34 years with MDS AML. And, I mean, there was nothing to point that this is an entity except probably his age. But then, as an adult physician, you do see patients at the age of third decade with all these conditions. But I think conscious efforts have to be made. And today with, as you said, NGS availability, you have to make an effort. You have to think of it. You have to search for this birth defects. You have to search for the abnormalities in the smear and marrows. You have to search for occurrence of other organ abnormality. And then, of course, specific test or the NGS panel. And if this becomes more and more known to the adult hematologist, we will pick up more cases. The difficulties will arise, as you said. We will pick up a lot of NGS abnormalities of unknown significance.
Yes.
Some of them may get significance later on. You will never know. After 5 years, 10 years. Yes.
Yes. So, sir, just one question, like in cases of, pancytopenia and aplastic anemia, up to what age you will recommend that we should look for stress cytogenetics as the, initial workup?
Probably up to about 45.
Thank you, sir.
Answer has varied, but I think stretch it to 45.
Sir, in these cases, sir, can I?
Yes, Gopinath.
Yeah, sir. As sir said, like nowadays with the help of NGS, we are picking up a lot of these mutations which are shown to be VUS. So that is basically these genes are not updated in ACMG guidelines. But then once after a good amount of clinical evidence accumulates, and then it will become a variant of proper significance. So in these cases, we do go with chromosomal fragility testing. And sometimes at the back of the report, they do give about proteomic prediction tools like mutation, twister, and all that. So they will tell whether this variant is damaging or non-damaging. So these can be taken as a surrogate evidence.
Absolutely. On the dot, yes.
Sir, I have a question to you. Two tests which we often do not get easily done in Mumbai. I want to know where you got it done, because the skin fibroblast chromosomal stress studies are not available. I have inquired a couple of times. And even the telomere length is still not available easily. So where did you get it done is my question.
Family was investigated at King's College.
Okay.
I presented this in 2 years ago, MHG meeting also. One of the family member was our chief guest also.
Okay.
Patient's husband was the chief guest.
Okay. Thank you, sir.
Flowfish helps us with measuring telomere length these days. So now, has there any labs started doing flowfish for telomere length? Any idea?
Not aware in Mumbai. What Lucknow? You have it?
So Lucknow, no, sir. We are just doing. I mean, our sir is just trying it, but we are not yet standardized actually.
In PGI Chandigarh, it's being done currently as a part of a thesis, so it's still to be validated yet, but it has been started by Dr. Srijesh.
A talk by a consultant from US on inherited marrow failure syndrome, and this discussion about telomere workup had come up, and she expressed how tedious it is and how difficult it is to avoid false positive and false negative. And she said, unless a lab has championed and doing it on regular basis, you will end up with two wrong results. And that was an eye-opener why probably labs are not going for it. You know, there are so many commercial labs, they would love to do all this, but probably it's very tedious and there are a lot of false positive, negative, unless you champion the test.
I have 2 comments to make, sir. The problem with the telomere length is only lab which is validated is in North Vancouver. That was doing for entire North America, and because of the assay and validation. So we also have trouble. On recent base, we have done 825 patients, but then we have a trouble. So nowadays, everybody's just moving to the genetic panel. And answering Dr. Varma's question, very often you'll do these gene panels and you'll find with the VUS, you do not know what to do with it. Is this significant or not? It is very often. What I advise you to do, just contact the expert. So Blanche Alter in the US, Shan Savage in the US, Indrajit Dokal for BKC, and Matthias Balamer, for CAMT and MECOM gene. Just email them, they will be really helpful. And had several situations where I was not sure whether this mild thrombocytopenia is related or not, and the gene mutation. They have been really helpful to guide you how significant the gene mutation is. So just contact the experts. That's a way of doing it. Thank you.
Dr. Ruchira, we can see you now. Yes.
Thank you. Sir, just a small question. A lot of our references that we get for inherited bone marrow failure syndromes have already been started on danazol and steroids. Whereas our understanding is that they really don't work very hard. So are there any specific conditions where you think danazol might have a role to play, or should that be a practice that should be discouraged?
No. I would say dyskeratosis congenita is extremely sensitive to androgens, and they do wonderfully well. And similarly, diamond blackfan anemia does extremely well with corticosteroids. So these are established treatment that should be made use of. And I showed both those cases, these things were used. And we use them quite often because it's not that tomorrow your patient is undergoing transplant. And those who have minor problems, they may not probably even should go under transplant. So it has to be very, very carefully calculated. So androgens for DC and steroids for diamond blackfan are very, very effective tools for months and years together. And even in adult life, when we use them, they are very effective. So I suppose we are reaching the time for the guest lecture. I will just like to re-emphasize few things. It's not all about NGS. I think it is clinical medicine. That is what I want to emphasize. And pediatricians are very strong in this field. The adult hematologists are not so strong. And that is the very important point of presenting this data today, because of this patient that we saw, 34-year-old man with AML, MDS-like features. There are a lot of things which, it's not just medical, legal and all. I would say you feel sorry that you missed it and a very wrong treatment is offered to the patient because you didn't diagnose it correctly. Just thrombocytopenia labeled as ITP, macrocytosis labeled as megaloblastic anemia, bone marrow just labeled as acquired aplastic anemia or MDS. If you just carefully examine the patient, carefully take the history, look at the family members, examine the family members, and do very sort of straightforward examination and simple investigations, you can get clues. And then you go for the specific test for, say, Fanconi's anemia or dyskeratosis or whatever else it may be. So I'm just going, I have lived for 40 years with clinical medicine rather than NGS. So I would say these things are very, very, very relevant, and NGS is there to help you. So over to Amit Khurana.
Thank you, sir. So thank you so much, sir, for the wonderful cases. Now it's a time to introduce our guest speaker for the day, Dr. Shruti Kakkar from Ludhiana. Dr. Shruti Kakkar has done her fellowship in comprehensive hematology oncology. She is associate professor at Department of Pediatrics, in charge pediatric hematology and oncology at the Anand Medical College and Hospital, Ludhiana. I invite her for a lecture on emerging complications in thalassemia. Over to you, Shruti ma'am. Thank you so much.
Thank you, Dr. Amit. I hope I'm audible.
Yes, ma'am.
Yeah. Can I share my screen?
Sure.
Is it visible?
Yes, ma'am.
Is it on the slideshow mode now?
Yes, absolutely.
Yeah, thank you. So first of all, I would like to thank the Mumbai Hematology Group and Dr. M.B. Agarwal for giving me this opportunity. When I talk of emerging, why I took this topic called emerging complications in thalassemia is because very often, not just by parents, but a lot of doctors around me, a lot of colleagues from other departments, whenever they, we send a reference, the first thing I get asked is, what is the lifespan of your patients and how well do they do once, they become older? So this is a talk probably dedicated to all the patients, and I was probably looking answers for myself to answer these questions that, I get asked on a routine. The other thing, it is not a lecture, it's kind of a learning exercise, and the literature on thalassemia is evolving at such a rapid pace that it was probably, impossible to go through each and everything. And, I believe I may have skipped a lot of references, and I would take this opportunity to learn from a lot of my teachers and colleagues who are there on the panel. So when we talk of emerging complications in thalassemia, we'll be going through this agenda where we talk of how the survival in thalassemia has changed, what are the complications that are now being seen in the aging population, and we'll try to review these individual complications. We will not try to, try to learn how to treat them, but just to recognize them and probably prevent them if we can, and then summarize with some data from our Thalassemia Daycare Center at Ludhiana. So as all of us know, thalassemia per se is not a single disease. It's a varied spectrum starting from beta thalassemia minor to beta thalassemia major, patients who require lifelong transfusion. The basic pathophysiology in thalassemia stems from the alpha-beta chain imbalance, which leads to ineffective erythropoiesis, resulting in anemia and iron overload, resulting to varied organ manifestations in thalassemia. Now, with each birth cohort, we have, papers have shown, registries have shown that there is an improved survival with each birth cohort, and patients with thalassemia are now living longer and longer. And all this has become possible because of availability of treatment, starting from, making blood transfusion regular, setting targets to 9 grams per deciliter, to availability of iron chelator, availability of bone marrow transplant, and finally, availability of cardiac MRI T2 star, which has helped us reduce morbidity due to cardiac failure. Now, this survival curve from UK Thalassemia Society has shown us that it's not just the drop in improvement in survival that has occurred. The improvement in survival has mainly occurred because of this decrease in the cardiac MRI, because cardiac iron overload, which was predicted by the cardiac MRI and treated as fast as possible to reduce the cardiac morbidity. Now that patients are living longer and everything is so good, why are we so worried? Why are we talking of emerging complications? Because with increasing age, there are age-related complications that happen in the normal population that are becoming obvious. Because of the chronic exposure to iron, the immunogenic blood products that these patients are receiving, and the disease-specific medications, there are specific adverse effects which are probably more common in this population as compared to the general population, or specific to thalassemia per se. Now, the age-related complications that are becoming common in patients with thalassemia have been depicted, like vascular events, pulmonary hypertension, and heart failure. There is increased incidence of cancers, and followed by liver diseases, which is becoming a much more common cause of morbidity and mortality in patients with thalassemia as compared to cardiac iron overload. Apart from cardiac failure, a lot of cardiac arrhythmias are being, newer endocrine problems are being noticed, and bone disease, which is becoming the most common cause of morbidity in patients with thalassemia. Coming to cardiovascular disorders, now we have seen that the cardiovascular complications in the past were responsible for 70% of deaths in patients with transfusion-dependent thalassemia. Now, the cause of cardiac complications in TDT and NTDT is different. The pathophysiology is different. However, as an overall, we are now moving away from heart failure because of the availability of cardiac MRI T2 star, and the problems that we are seeing more often now are arrhythmias, pulmonary hypertension, and thromboembolic disorders that are becoming more common. Now, this graph is something all of us have seen, the landmark paper by Kirk et al., which had shown that the cardiac MRI T2 star of less than 6 millisecond was predictive of cardiac failure, resulted in cardiac failure in 50% of individuals within 1 year. And this study was conducted on 652 thalassemia patients with a mean age of 27.1 years. And at the end of 1 year, there were 84 episodes of heart failure that were noticed in this study. Now, this is something we all know, but the other side of the story that probably, it's not highlighted much is that within the same cohort, there were 100 episodes of arrhythmias also that were noticed, 79 of which were atrial fibrillation. And the incidence of this arrhythmias was also affected by the MRI T2 star. The mean cardiac MRI T2 star in this population was about 13.5 millisecond. And about 14% of patients who had cardiac MRI T2 star of less than 6 millisecond developed arrhythmias in the next 1 year. As far as arrhythmias is concerned, it is related to the current cardiac MRI overload also. But in case, we know heart failure can be reversed, the cardiac MRI T2 star become normal with intensive chelation, but the risk of arrhythmias does not decrease with the age. Now, once a patient develops arrhythmia, we can have expert cardiology call, but our strategy would be based on rhythm control, rate control, and finally anticoagulation. As we know, our patients with thalassemia are at a high risk of thrombosis. Moving on to pulmonary hypertension. Pulmonary hypertension in thalassemia is attributed to hemolysis, which leads to depletion of nitric oxide, a high cardiac output state, small pulmonary emboli that can happen in patients with DVT. Now, this large study conducted by the WebThal group had shown that in about 1,309 patients with thalassemia, out of which 977 were thalassemia major, they did the tricuspid valve regurgitant velocity, and right heart catheterization was done in patients with the TRV values of more than 3.2. Now, in this group with TRV values of more than 3.2, 33 underwent right heart catheterization, and in that, about 27 were detected to have pulmonary hypertension. Now, the prevalence of pulmonary hypertension in this group was 2.1%. 2.1 per se may not look a very huge percentage, but when we compare it to the general population, it is almost 10,000 times the prevalence of pulmonary hypertension in general population. It was much higher in patients with transfusion thalassemia intermedia as compared to thalassemia major. And the positive predictive value of TR jet velocity of more than 3.2 meter per second was about 93.9%. And age and splenectomy were considered to be the most important risk factors contributing to pulmonary hypertension. And this pulmonary artery hypertension was also associated with functional impairment, which was documented by a 6-minute walk test. Now, as we can make out, these patients with transfusion, the thalassemia intermedia, non-transfusion dependent thal patients were actually older. They were higher percentage of splenectomized patients in this group. Their HB was lower, and of course, ferritin was also lower because it doesn't have much correlation in thalassemia intermedia. Now, when this group was followed up for another 6 years, it was also documented that the all-cause mortality and the cardiopulmonary mortality was much higher in the group with tricuspid jet velocity of more than 3.2 millisecond, rather than the group which was between 3 to 3.2, which was kind of a gray zone. And if the patient with increased TRV jet velocity received appropriate treatment that led to improvement in the tricuspid jet velocity, then the all-cause mortality and the cardiopulmonary disease-related mortality came down, which makes a strong case for our patients with thalassemia intermedia as well as thalassemia major to undergo regular screening for pulmonary hypertension and treatment with the available agents like sildenafil, endothelial receptor antagonist, prostaglandin, and as simple things like improving the hemoglobin levels, putting a patient with NTDT on regular transfusion, and improving iron chelation. These simple practices can improve the tricuspid jet velocity and prevent the overall increased morbidity and cardiopulmonary morbidity in this group of patients. Moving on to thrombosis. We have all heard of thrombosis in patients with NTDT, but the largest body of evidence, the largest study of thromboembolic events amongst thalassemia comes from the Middle East, where about 9,000 patients were followed up and about 1.65 patients developed thromboembolic episodes. The thromboembolic events were, as all of us know, more common in patients with TI as compared to thalassemia major, Venous venous thrombosis was common in intermedia, whereas arterial arterial events were more common in thalassemia major. And the risk factors were the thromboembolic episodes were more common in females, those who were splenectomized and had lower HB. The next study that showed us the incidence and prevalence of thrombosis and the factors affecting it was the optimal care study, where we followed up patients with non-transfusion dependent thalassemia, and thrombosis emerged as the fifth commonest morbidity in this group of patients. And as we studied the effect of treatment on the thrombosis, the risk factors which were documented were again splenectomy, iron overload, age, and lower hemoglobin. And with this, we actually found out that this study highlighted that if the platelet count was more than 5 lakhs and the nucleated RBCs was more than 3 lakh in a patient who had been splenectomized, there was a high risk of developing thrombosis, and such patients were actually recommended to be put on aspirin to prevent. And the other things that could be done were, improving the transfusion, hydroxyurea therapy, and iron chelation may help. Anticoagulation, if a patient developed thrombosis, the anticoagulation had to be done as per the standard guidelines, and the transfusion therapy can be done for the secondary prevention of these thrombosis. Now, something interesting which was published in this December Indian Pediatrics was the prevalence of premature atherosclerosis in children with transfusion-dependent thalassemia. Now, in this study, which is from India, the authors had found that amongst all age groups, including children between 2 to 5 years of age, there was a significantly higher carotid intima medial thickness, which is seen as a marker for premature atherosclerosis. Now, these are documented not just from India, but from other centers also. And we need to see where it goes and how, this finding of higher carotid intima medial thickness will attribute to atherosclerosis in future. Now, overall, we know that the cardiac MRI T2 star has improved our chelation practices. UK model has shown that it has decreased the heart disease prevalence and the incidence of heart failure. And with that, the liver disease per se is becoming a major cause of mortality. And as per the study from Greece, they had shown that the mortality from liver disease is slowly increasing. And this was documented by a large study which was conducted over 10 years. Now, what are the factors that are affecting liver functions? Now, all of us, kind of know that it's iron overload, viral hepatitis. There could be drugs that we're using, desferrioxamine, deferriprone-induced transaminitis, and there could be other factors which are not thalassemia related, like alcohol, obesity, drug abuse. So with all that, presence of iron overload as well as hepatitis B and C, there is, reactive oxygen species production, there is altered immunogenicity, and hepatitis C plus iron is supposed to be synergistically acting, causing a lot of fibrosis and cirrhosis and development of secondary hepatocellular carcinoma in patients with thalassemia. Now, iron overload and hepatitis C both have actually shown effect on the liver fibrosis. And it's not just, the iron overload, it is also the duration of iron overload that affects the prevalence of fibrosis. And as documented by the study published in Journal of Hepatology, that amongst patients with thalassemia intermedia, over a period of 1 year, there was actually an improvement, a fall in serum ferritin and the transient elastography levels as compared to the patients who were non-chelated. So as the duration of, iron overload increases, that affects the fibrosis in this subgroup of patients. Another study which was conducted in about 200 patients post-transplant with, liver biopsies done on an annual basis to see the effect of hepatitis C as well as iron overload, had shown that the probability of fibrosis-free survival is least in patients who were hepatitis C positive and had high iron overload. So that again, stresses the need of controlling the iron overload and treating hepatitis C, which has now become much easier with the availability of directly acting antivirals. As far as our drugs are concerned, the Deferasirox in the optimal study had shown that how it can improve the cardiac iron overload and cardiac MRI T2 star will got better. But not just on cardiac, Deferasirox actually had an effect on liver fibrosis. And in patients who were given Deferasirox, had actually shown an improvement in the Ishak fibrosis score over a period of 3 years. Now, moving on to renal complications, which has actually become, a important topic with a lot of studies coming up, but clinical correlation still needs to be done. Renal disease and thalassemia is actually a combination of chronic anemia, iron overload, as well as the chelation practices. Now, with the proximal tubule damage happening secondary to the hemosiderin deposition and damage to the brush border epithelium, we have seen a lot of studies which have shown there is increased urinary excretion of these compounds like N-acetyl glucosaminidase, beta-2 microglobulin, and calcium. And just seeing the correlation between serum ferritin and GFR, which was measured by cystatin C, we saw that a higher serum ferritin was associated with the lower GFR. The mechanism of renal disease is actually, as I said, it's multifactorial. The chronic anemia and hypoxia actually reduces the vascular resistance. There is expansion of the glomerular capsule, which later on leads to low GFR. There could be damage to the tubular cell because of iron overload. And finally, the iron chelation, the long-term toxicity. There are case reports of renal failure, acute kidney injury happening with desferrioxamine and Deferasirox. But the long-term use of Deferasirox, we've heard about creatinine going up in about 1/3 of the patients, but it has been shown to be remain stable at a certain age and no long-term effects were seen. The glomerulonephritis in patients with thalassemia could also be complicated by various transfusion-transmitted infection, and the kidneys may also get hit because of the hepatic and the cardiac dysfunction because of the iron overload. Moving on to bone disease, the osteoporosis and bone disease in thalassemia is an evolving topic. The cause for bone disease is, it's under review and not many reasons are known. It is considered a heterogeneous group of condition which constitutes bone deformity, pain, marrow expansion, reduced bone density, and fractures. Now, what differentiates thalassemia bone disease from the regular osteopenia, osteoporosis that we see in older patients is because of a younger age at which it presents. There are a multitude of risk factors which are contributing to this thalassemia bone disease. Their response to bone preserving agents is different, and there is this epidemiology of fractures that happens in thalassemia bone disease. Now, the mechanism for thalassemia bone disease are, as I said, they're multifactorial, the most important being the marrow expansion, which is happening because of ineffective erythropoiesis. Iron overload can cause a reduced bone density. Hormonal imbalances, hypogonadism, hypoparathyroidism can cause low bone mass and loss of calcium through the renal tubules, or it may be because of the long-term chelator toxicity. Apart from that, there are various genetic factors which actually affect the prevalence of thalassemia bone disease, which may be polymorphism of different genes that may be involved. Now, bone disease in thalassemia has been a topic of research in a lot of studies. One of the largest studies that I could encounter was in patients registered in the Thalassemia Clinical Research Network, where bone mineral density was seen at both spine and femur. And apart from that, vertebral anomalies were seen by the X-ray absorptiometry. And it had shown that about nearly 50% of the patient had low bone mineral density at the spine. And the predictors of low bone mass included higher age, lower weight, hypogonadism, and increased bone turnover. And about 36% patients in this study had history of fractures. We have more and more literature coming on metabolic bone disease from our country as well. And, this was again another set of complications published in this Indian Pediatrics December issue, where in patients who less than 19 years from KMC Manipal had shown that low bone mass was seen in 8 out of 37 patients, and 4 had actually experienced vertebral fractures, and 3 out of these 4 patients were actually less than 18 years. So there is presence of bone disease, and once we know that our patient has a bone disease, we can optimize the general management, do proper transfusion, maintain good hemoglobin, intensify chelation, calcium and vitamin D supplementation, and hormonal replacement therapy may be given. Zoledronate, alendronate, and these are some of the bisphosphonates all of us have been using, and there is that has in many studies has shown that it increases the bone mineral density. Although we need to be looking out for the adverse effects in patients with thalassemia, and there are other drugs which are in pipeline. Zinc is deficient in a lot of patients with thalassemia, and zinc supplementation has been shown to improve the bone mineral density. Teriparatide, another newer molecule, but there have been incidences of some bone marrow, some cancers. That's why there is some doubt about the use of teriparatide. Denosumab is a newer agent, which is a monoclonal antibody against the rankle group. So denosumab has been used in a small group of patients, in about 30 patients with osteopenia, and has shown improvement in bone mineral density by about 10% in these patients. Now, a large body of evidence is now getting accumulated about malignancies in patients with thalassemia. And what could all be the factors that are contributing to increased risk of malignancy? It could be iron overload induced oxidative damage, the immunological aberrancies caused by the iron overload, immunomodulation secondary to transfusion, various viral infections like HTLV, long-term use of hydroxyurea, and chronic bone marrow stimulation secondary to the chronic anemia. Now, since the beginning, like 1950 to 2003, registries had shown some, increased incidence of malignancies in patients with thalassemia. There was about 1% incidence of malignancy in the registry from UK Thalassemia Society amongst 850 patients. Of late, what we have seen is that there is an increasing incidence of hepatocellular carcinoma because of varied reasons in patients with transfusion-dependent thalassemia. Now, the reasons we have discussed some of them, and these are the various cancers that can happen: papillary carcinoma of thyroid, HCC, renal cell carcinoma, and as well as, the hematological malignancies in patients with thalassemia. Now, the largest body of evidence about hepatocellular carcinoma actually comes again from Middle East. There are about 153 cases of HCC that were reported mainly, in 2000s, and it's mainly from Italy and Greece, where they had shown the prevalence of hepatocellular carcinoma is actually as high as 1.66 to nearly 2% in patients with TDT and NTDT. And what is characteristic about this hepatocellular carcinoma is that the patients are much younger as compared to the general population, and liver stiffness of more than 12 kilopascals was actually an independent risk factor for hepatocellular carcinoma. So based on this, the group, the ICET network, had actually developed these guidelines for surveillance, in which in a patient who's less than 30 years and there was evidence of risk factors, it is recommended to do ultrasound abdomen and alpha fetoprotein every 6 months. If available, elastometry can be done every 6 to 12 months. And if you find a nodule, then consult has to be taken. Now, moving on to, what is the importance? Why are we trying to do both ultrasound abdomen and alpha fetoprotein? Is that ultrasound abdomen has a lot of observer variation. Small lesions may be missed. That's why a repeat scan is advised every 6 months, because the doubling time of hepatocellular carcinoma is about 200 days. And alpha fetoprotein, again, the literature is not really definite. A lot of patients who were diagnosed with hepatocellular carcinoma had actually normal AFPs at the diagnosis, but it's the trend, that would be helpful. So if a patient has had hepatitis C in the past or has had iron overload or liver fibrosis, then follow up with both alpha fetoprotein and ultrasound abdomen. Transient elastography will not pick up the HCC, but it will help us, see the progression of hepatic fibrosis. The endocrine complications have been a concern for a long time, and we have seen commonest hypogonadism being the commonest endocrine disorder now, and it is affected by the age at starting chelation and the adherence. But what is now being seen more and is being talked about is the adrenocortical function. There could be subtle impairments in the adrenocortical functions in patients with thalassemia. They may not be clinically relevant, but in periods of stress or infection, it may be helpful to know if a patient has adrenocortical dysfunction. And now various studies are documenting low peak cortisol levels. Now, recently there's a paper with which has shown actually 3 cases which were diagnosed in acute setting in the age group of 40 to 54 years. And these patients were actually being, in the phase of sepsis, there was one patient had refractory shock, non-responsive to inotropes, and helping the patient was actually helped with supplementing steroids. The other one had refractory hypoglycemia, which was not responding to the increased GIR. And finally, the last one was picked up on a pre-operative period when the patient was due for surgery. Now, with increasing lifespan, increasing life, the patients are now thinking in terms of having a good quality of life. And when we talk of good quality of life, having a family and achieve the reproductive potential are some of the common goals in life of these patients as well. So there is this survey on paternity in patients with transfusion dependent thalassemia, which was done across 10 countries by the ICET group, and it had shown amongst about 1,000 thalassemia patients, there were about 1/4, about 240 who were married or in a live-in relationship, and of those, about 184, nearly 75% had a child within the first 2 years of marriage, and 150 of this, nearly 80% pregnancies were natural conceptions. About 12% patient needed some, spermatogenesis induction with the hormones, and some patients, about 7%, went ahead with the assisted reproduction or sperm donation. So it seems that the prospects for fatherhood are potentially good in this group of patients. Now, fertility in females is a little bit, more complex as compared to male population, and there are multiple factors. Oxidative stress per se is detrimental to the reproduction in adult females, and with the iron overload, the oxidative stress is actually increased to a higher level. Now, evaluation of fertility, there are different techniques which are available. LHFSH is good to diagnose hypogonadism, but its relation with the fertility parameter has not shown to be good, whereas the anti-Mullerian hormone and the antral follicle count are usually not affected by the period of cycle. So especially the AMH, so they can be used as a marker for fertility. And both AMH and the antral follicle count has actually shown an inverse relationship with iron overload as well. So with this, aspect on fertility, between, over last 50 to 60 years, about 400 patients of thalassemia have experienced pregnancies. The maternal mortality was about 4.5%. there is high risk of miscarriages and multiple gestation because in vitro fertilization techniques and assisted reproductive techniques are used in a lot of these patients. There could be complications like IUGR or low birth weight. It is important to have proper counseling and planning prior to pregnancy, starting from, testing the partner, looking at the drug chart, withholding certain drugs, and or intensifying chelation early on so that the iron overload can be taken care of. Moving on to some of our experiences from the Thalassemia Daycare Center in Danan Medical College and Hospital, Ludhiana. This is the current distribution of patients. There are about 100 patients who are now above the age of 18 years, and about 1/3 of them are female. The liver iron overload, only 14 out of this 160, which is more than 10 years group, was actually normal, and nearly 50% of our patients have severe liver iron overload as per the MRI T2 star. Cardiac iron overload is there. Severe cardiac iron overload is there in nearly 10% population. Moving on to bone health, there is high prevalence of osteopenia and osteoporosis. Nearly, out of this 160, nearly half the patient have osteopenia at the lumbar spine as well as the femoral head. We've had about 6 patients have experienced fractures in over last 5 years. 4 had in the extremity and 2 vertebral fractures, but there was history of trauma present in all of them. What has recently happened over last 2 to 3 years is avascular necrosis of hip. Now, avascular necrosis of hip is actually more, common in patients with sickle and sickle beta thal. But these 4 patients with transfusion-dependent thalassemia developed avascular necrosis of hip between the age of 20 to 30 years. Male is to female ratio was 1:1. The common factor in all of them was high iron overload and poor adherence to chelation. None of them had been splenectomized, and all needed a hip replacement surgery. As we were talking of adrenal dysfunction, we could do only the basal cortisol levels. We could not do a ACTH stimulation test, but nearly 15% of patients had shown low basal cortisol levels in a study from our center. Moving on to pregnancies, we've had 5 pregnancies in 4 patients, 3 transfusion dependent and 1 non-transfusion dependent thalassemia in last 10 years. The age of conception varied from 27 to 36 years. All of them were actually spontaneous conceptions, and 4 healthy newborns were delivered, 2 boys and 2 girls. 1 patient is currently pregnant at 26 weeks. All of pregnancies, the delivery was by LSCS, and the serum ferritin at the time of conception varied from 1,500 to about 4,000. And in 2 of these pregnancies were actually unplanned, so the patient was actually on deferasirox, but she denied to undergo MTP and continued with the pregnancy, and touchwood nothing, the child is now normal. Both the kids are now normal. And moving on to outcome, the total number of patients registered since 1999 is about 507. Now, we tried to contact about 254 are under regular follow-up with us. They receive transfusions at our center. Nearly 50 of them are being followed up for their consults. But over last so many years, we've lost 33 patients to various problems, and most common was actually the infections. Dengue being the commonest one. 1 patient had septic arthritis in the background of an HIV positive status. 2 patients had CNS infection, and 1 had COVID-19 infection. The patient with COVID-19 was actually beta sickle thal and had severe hypoxia, and we lost him to COVID-19. And 4 patients died of complications of BMT, which were not done at our center. We could not contact nearly 100 out of these 500 patients. So this is probably out of 400 odd patients. And 1 patient had actually died because of anaphylaxis to interferon for treatment for hepatitis C. So with that, I would like to summarize and say that patients with thalassemia are now surviving longer. We may be seeing newer and newer complications that will emerge with time. What we need right now is a nationwide registry. Now, whatever literature we have about emerging complications, a lot of it is coming from Middle East and UK, and these are big thalassemia registries. So we need a nationwide registry to find out what happens to our patients with thalassemia and how they, become older and how they survive. And I would like to thank this wonderful group of staff without whom all this wouldn't have been possible. Thank you.
Thank you, ma'am, for that excellent lecture. We will give you a break of 5 minutes before the question answer session, because Agarwal sir will declare the results of the quiz which took place in the morning on hemochromatosis. I hand over the dice to Dr. Agarwal sir to declare the results.
Thank you, Amit. Thank you, Shruti, for the beautiful, wonderful presentation. There's so much of learning. You have put in a lot of hard work and a lot of data. Thank you so much. So, okay, we'll just share my screen. So we go to the Sunday quiz, which was put up in the morning. It was related to hemochromatosis. You were given 10 statements and you had to pick up the false one. These were the 10 statements. I'll go over this for a purpose. So it comprises a group of inherited disorders. That is correct, because these are inherited disorders and these are due to failure of the hepcidin, which must respond to the iron stores and block the iron absorption. That doesn't happen. I'll go to the fourth one. The commonest symptom is fatigue is correct. Many of you have replied that this is a wrong statement, but this is the commonest symptom. Liver disease and arthritis are the most common clinical manifestations is also correct. Cardiac damage, etc. is not so common as liver disease and arthritis. There is a distinctly increased risk of infection with this organism, so this is correct. MCV is elevated above 94 is also correct. Transferrin saturation goes up before ferritin is also correct. It has been shown that the dietary restrictions do not really play a huge role, so they are not of proven benefit. There's no point in restricting the dietary iron. Many of you answered the 10th one, but there is an increased risk of breast and colorectal cancer. This is a correct statement. Before I discuss further, let me show you this particular cartoon. This is the global distribution of hemochromatosis. Most of these patients are due to HFE gene mutation, and the disease probably began, this mutation probably began in the northern Europe, and with the global migration, it has moved to various places. What you see in yellow are the areas where hemochromatosis is common. United States, Brazil in South America, South Africa here, the North Europe, of course, and Australia. Rest of the world, there are cases, and those are probably all due to migration. What you see here is this pyramid, which reflects the expected clinical manifestation. Death goes up by 1.2-fold. Liver cancer goes up by 12-fold. Arthritis goes up by 8-fold. Advanced hepatic fibrosis, 8% in women who are protected by their menstrual losses, and 25% in men. Clinically significant iron overload, 13% of women, 40% of men. Elevated serum ferritin, 57% of women, 88% of men. Elevated transferrin saturation, 73% of women, 94% of men. And yes, the commonest is this particular mutation. So how do you suspect hemochromatosis? Family history, biochemical trigger, that is elevated ferritin and transferrin saturation above 45. Hematological trigger, MCV more than 94. And clinical trigger, arthritis, liver disease, that is either large liver or abnormal enzymes. And there may be some other compatible clinical feature. Diagnosis, Northern European origin. You look for the HFE mutation. transferrin saturation and ferritin level, which becomes the starting point. And for the rest, it's transferrin saturation, ferritin level, and then probably you go for the various kind of genetic mutations in select patients. It's not really necessary to go to the mutation workup. Risk assessment, evaluate whether there is no arthritis or arthritis. If no arthritis, ferritin less than 1000, APRI less than 0.4, Fib less than 1.1. So all these are absent. There is a very low risk of patient getting into advanced liver fibrosis. And if these are all high, then there is a high risk. So keep measuring the liver iron concentration by non-invasive tools at the moment and look for the portal hypertension. And this is, if you have low risk, then therapeutic phlebotomy is enough. If you have high risk, then therapeutic phlebotomy, of course, but keep looking at the regression of the fibrosis. If there is no regression, keep looking for development of liver cancer. And if there is regression, then there is a low risk of liver cancer. You do not have to do something else. Follow-up, maintenance phlebotomy are required. Family screening should be done. And cancer surveillance. And here comes this breast and colorectal cancer, which has got a higher incidence. The statement that was wrong, and I'm afraid this was not picked up, that hemochromatosis results from transfusion-dependent and non-transfusion-dependent anemic disorder, thalassemia, myelodysplasia, was a wrong statement. Hemochromatosis is the term used for the genetic disorder. This is hemosiderosis. This is not hemochromatosis, and you do not consider them under this umbrella of hemochromatosis. So it does not result. So this is a wrong statement. Answer expected from you was 3. I'm afraid first time in last 2.5 years, no one has given a correct answer. So first time we do not have a winner. Apologies for that. I'll stop here. Thank you for participating. We had over 40 people who attempted, but majority got biased by the colon and breast cancer being the wrong statement. Anyway. So we go back to now the question and answer session. Amit, take over.
Dr. Amit, you're muted.
Yeah, thank you so much, sir. So we'll start with the question and answer session. We'll take it from the discussions here. Dr. Priyanka Agarwal, your question, please.
Thank you, ma'am, for such an excellent lecture. My question is, how do you manage patients who develop pulmonary hypertension, especially the transfusion-dependent ones?
So Priyanka, first thing, I do not manage them. They have to be managed by a expert cardiologist, that too somebody who has experience in managing pulmonary hypertension. Now, what I read during when I was preparing for this talk is a patient who's transfusion dependent. Of course, you need to optimize the hemoglobin levels. Improve the chelation. Plus, what is preferred is to have 2 agents. We have, multiple drugs. We have sildenafil, we have bosentan. So not just give 1 drug. 2 drug combination was supposed to be better in improving pulmonary hypertension. Now, this is what the literature says, but in my experience, I have managed 3 patients so far with the transfusion-dependent thalassemia, with the non-transfusion-dependent thalassemia who were developing progressively increased, values in pulmonary hypertension. So they were put on transfusion and things have become better. There's one patient who was actually put on thalidomide because she was not able to, receive transfusions, and on thalidomide, she developed increased pulmonary hypertension. So she has again gone back to transfusion after a lot of counseling. So that's my experience of managing pulmonary hypertension. Apart from that, I would go by what literature says, 2 drugs plus anticoagulation.
Okay. Role of aspirin, ma'am, in this situation?
So aspirin, as I had shown in the slide on thrombosis, if there is platelet count, splenectomized platelet count more than 5,000 and nucleated RBCs more than 3,000, patients need aspirin prophylaxis. Somebody with pulmonary hypertension, we are already talking of anticoagulation, so that's a decision that needs to be taken. Aspirin versus warfarin, there are no head-to-head trials, so that is an individualized decision which will have to be taken in discussion with the cardiologist, the patient, and yourself.
Okay. One more question, ma'am. When do you think of adding levothyroxine in a patient who has a TSH more than 10, maybe?
So levothyroxine.
Transfusion dependent setting.
So levothyroxine in patients with transfusion-dependent thalassemia, of course, we monitor serially, right? So you look at TSH, but as well as that, you follow up the clinical history and you look at the T4 levels, free T4 levels as well. If the TSH levels are going up or there is low T4 with high TSH, that's when you will add on, levothyroxine and modify it as per the weight, the dosages, and monitor TSH at follow-up 3 monthly.
Okay, thank you, ma'am.
And thank you, Priyanka, for that, the newer IP papers that I had shown. Thank you for that beautiful commentary that you and Vinita ma'am have written in the December issue.
Thank
You've
you.
compiled it really well. Thank you.
Thank you.
Thank you, Dr. Priyanka. Dr. Urmimala Bhattacharya, your question, please.
Thank you, ma'am, for this excellent talk. So, first of all, I have a submission, a comment to make. Basically, you see in thalassemia, patients do face these, as such, the disease-related complications, but also there are complications because of this lack of supportive care. So, if you see in our country, basically, most of these patients are not have access to proper transfusion facilities. The hemoglobin is not maintained what should be maintained as per the TIF guidelines, 9.5 to 10 for most of these patients. And also there is lack of availability of these drugs, that is chelating agents, for most of these patients. And I don't think that it is covered under any schemes also. So for Ayushman Bharat or anything, so that the patients can get avail of. So those also lead to a lot of complications, because we in PGI, we manage this adult thalassemia clinic, and here all these patients come with lots of complications, extramedullary hematopoiesis, poor hemoglobin targets over a period of 20 years of 6.57, and also very high ferritin. So I feel that something should be done, means from the government and all, so that the availability of the chelating agents can be made available.
So,
And
Urmi, I think within Punjab now the chelators are available free of cost through the civil hospitals, and patients are getting regularly. I know of other thalassemia societies who have been telling that yes, it is available. Of course, because it's a new venture. There are little, availability issues every now and then, but things will fall in place. I think for last 2 years, patients are getting chelators. Even desferrioxamine is available through the Punjab government. I think there are panelists from other states who can give their opinion. As far as transfusion is concerned, I think we need to.
1 minute. Dr.
Yeah,
Anil Sharma, can you mute yourself? Dr. Anil Sharma, please mute yourself. Okay, go ahead, Shruti. Sorry for that.
Yeah, so as far as hemoglobin levels are concerned, what we need to do is repeated counseling. You need to hammer that into the, head of the patients right from the beginning, and you have to show them. You have to lead, and what we have done recently is, a mentorship program. So an adult thalassemia mentors a young thalassemia patient. So that's how they show that, I have maintained a good hemoglobin, and that's how I've reached this age of 40 years. And that's how you can also reach. So it is repeated counseling. Patients will maintain if they see good results. Chelators are available, and there is a bone marrow transplant program by Government of India. I think the steps are being taken, and we'll be there. We'll have enough support. Psychosocial issues, yes, they are there.
Service provider, can you block Dr. Anil Sharma? Can you make him mute?
A couple of years back, I had actually given a talk on pain in thalassemia, and that was presented in one of the conferences in PGI. Pain is becoming a common, I can actually give an entire talk on pain. That's why I didn't include it here. But that's something which is coming up, and our paper is there for publication. Hopefully it will come out soon, and then we will know more about. And as I said, we need to compile our own data, our own, what is happening to our patients, rather than quoting studies from Middle East or UK for that matter.
Yes, ma'am. As you mentioned, a national registry is the need of the hour. And From that only we can get the data from all over India and how
All over.
we can streamline the management. Thank you, ma'am, for this excellent talk.
Thank you, Dr. Urmimala. Dr. S.P. Verma, your question, please.
Thank you, Dr. Surti, for this nice talk. And as you mentioned, in our UP state also, for all the thalassemiacs, we have chelation and transfusion that is totally free of cost by government. Only time when we had problems was during COVID period when the donors were not available, for blood donation. That time they had to, donate. Otherwise, it is totally free of cost. I wanted to know, like, in your routine practice, how frequently do you monitor and with what investigations to look for all these complications which you have mentioned in your presentation? So what is your strategy, like every 6 months or every year, like T2 MRI and other investigations, like, monitoring for developing endocrinopathies and all? So what is your strategy in monitoring your patients?
Right. So common things like CBC, where we're looking for neutropenia and thrombocytopenia, it's actually done at every visit. So which is complete, it's included in the daycare panel and it's done at every visit. LFTs and RFTs are monitored every six months, but SGPT and creat are again in that, daycare package where it is done at every visit because, that's how we were developing it. So to look for the chelator toxicity, right? Urine examination every 6 months, we do it with the urine, with the RFTs. As far as MRI and ECG are concerned, they are done annually. In a patient who's had a normal MRI and a normal liver or a cardiac, which doesn't really happen all the time, we can actually schedule it 2 years later. So it depends. You have a very bad MRI, we'll repeat it in 6 months to see how the chelation is, what the chelation is doing to the patient. If it's a good one, we'll, instead of annual, we'll do it, once in 2 years. Bone mineral density is checked annually after the age of 10 years. Annual endocrine screening with the thyroid, PTH after the age of 16 years, rest after the age of 10 years, our fasting glucose. We were doing glucose tolerance tests, but during COVID and sometimes in winters, it's very difficult for a patient to reach on time and do the GTT, and they have to go back. They come from far off places and the weather is not so good here. So we've right now moved on to RBS. Let's see if we go back to the GTT. And I think Mamta ma'am being here, we are coming up with the thalassemia guidelines, and you'll have an entire chapter on monitoring with the table to follow, which is as per the Indian needs, what needs to be done. So that can be used as a reference for following up these patients.
Thank you. And regarding these pregnant females and modes of delivery, so is it mandatory to go for cesarean, or it is just an obstetrical, indication-based, delivery mode?
So none of our patients had actually cardiac dysfunction. So it was, the LSCS was actually based on the, obstetric. The first 2 pregnancies, I'll tell you, we were scared, just subject the patient to a normal delivery. The patients were scared, we were scared. So LSCS seemed easier, and the gynecologist, anesthesiologist, everybody was comfortable. But as per the literature available, it is not necessary to go for LSCS. It should be as per the obstetric indication. Of course, you need to assess the pelvic diameter and the bone structure. If there are any bone abnormalities, then that may cause problems with the normal delivery. So that's when you need to go for LSCS. Otherwise, it's as per the obstetric indication.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Dr. S.P. Verma. Dr. Sujata Sharma wants to ask a question: can thalassemia be given thromboprophylaxis right from the beginning to prevent thrombosis?
So I think putting every thalassemia patient on thromboprophylaxis with a prevalence of 1 to 1.5% doesn't really, seem right. Of course, we need to collect literature and see what happens. But, there are high-risk conditions. Somebody with a family history of thrombosis and, there are cutoffs which are given. That's when you go ahead and put thromboprophylaxis, and not routine for everybody as such.
Okay, thank you, ma'am. Dr. Rajat Bhattacharya, your question, please.
Yes, okay, excellent talk. Can I ask, do you have any data on psychological aspect? What happens to the quality of life, and do they get into more depression as they get more older? The second question, do you have any data on full-time employment? I mean, are they able to have a functional life so that they can earn their own cost of treatment?
I think we have some data on that, and that will be kind of published with the pain paper, because we actually compared that pain with their employment, whether they were employed or unemployed, and what was their daily physical exercise. But about out of 100, about 20 of our patients are self-employed. They have their own businesses. About 20 have employed with different services. About 60 are currently doing their studies. 18 to 25 is the big group that is there with our patients. As far as psychological depression is concerned, no, we haven't looked at it, but we have looked at body image issues in patients with thalassemia, and thankfully the younger generation, the 10 to 18-year-old, because of transfusion and appropriate chelation, they didn't really have a lot of body image issue in our cohort of population. But that the depression and psychosocial issues would be good to look at in future sometime. Yes.
Thank you, sir, for that question. Dr. Hamza Dalal, your question, please.
Thank you for the informative talk, madam. So, recently, with the increasing lifespan of thalassemia patients and the increasing availability of liver transplant, we had 2 referrals from the liver team for those patients who were transfusion-dependent hemoglobinopathies. One was thalassemia, one was sideroblastic anemia. So, actually, we had a very animated discussion whether these patients are fit for a liver transplant. So, what are the factors that you consider for these patients? Both the patients were 25 and 28 years old.
So that's a new situation. We haven't really come, across such a situation. Amongst patients with liver dysfunction, 2 of our patients have actually shown advanced cirrhosis, but they are currently on medical management. As far as liver transplant, I can talk about thalassemia. I will not be able to comment on sideroblastic. I'll have to look at literature for that. Thalassemia is concerned. In case we need to go for liver transplant, I think one thing I will look at it is our cardiac. If the cardiac dysfunction is already too pronounced, then that may be an issue. Apart from that, longevity wise and transfusion wise, I don't think that would be a contraindication. But yes, we can look up some literature. I haven't really read about liver transplant in thalassemia per se, but yes, definitely I would look at the cardiac picture before taking up a transplant for taking up a patient for liver transplant.
Thank you, ma'am. Thank you so much.
Can I put a comment here? There's an increasing trend nowadays for a solid tumor transplant that you do a stem cell transplant, you may reduce intensity from the same hematome to a bone marrow transplant first, and then follow up with a stem cell transplant. So you change the immune system, and then if you use the same donor to do a solid organ transplant, you don't need long-term immune suppression. This is being increasingly done. So something, if it's possible to do a stem cell transplant on the same donor first, do a microclimate, at least a next time, and then do a solid organ transplant, so that you don't end up with a long-term suppression. Yeah, so that is increasingly being done. I guess
that's interesting.
Yeah, being done.
So this hematopoietic stem cell transplant followed by liver transplant, would that be a full HLA match, or a mismatch would be acceptable? I mean, that's really interesting.
Matter, because now in stem cell transplant you can do with haplomat and everything.
With haplomat.
Use the same, even with the same donor, you do a liver transplant or a kidney transplant. It's being done in pediatrics, at least. Adults, I'm not entirely sure, but this new concept is being done.
Thank you, sir. Thank you for your input.
Thank you, sir. Dr. Jagdish Chandra, your question, please.
Yeah, thank you, Dr. Shruti, for that very informative talk. And I can understand you have put in a lot of effort in reviewing the literature and coming up with such a nice overview of the emerging issues that we have in the management, the complications as well as the other issues. I don't have specific questions. I would just make certain comments. She very rightly pointed out the new complications that are emerging, and renal ones are being talked about now. Just in addition to what you described, there is some literature on RTA-like picture in patients who are receiving Thalassemia. In fact, we also did some little work on that, is still unpublished, but we found some cases who had RTA-like picture with the glucosuria and amino aciduria in those who were receiving Thalassemia. Second, obviously, you talked about adenocortical complications being talked about much more nowadays, in addition to the other endocrinopathies that we talked. And in the bone disease, one issue that we published some, I think, 10 years back was ulnar deviation of the patient in the patients who were receiving differiprone primarily, since because at that time Thalassemia was not available. And there are similar data published from Dr. Merchant's team and from SGPGI. There is ulnar deviation because of the ulnar shortening, and that was being noticed. And in fact, after that, our orthopedics department did a thesis on ulnar the wrist joint changes in patients with thalassemia, and they reported that with long-term use of these chelator, particularly the differiprone, there is a shortening of ulna. So these are certain other problems that one can at times come across. One thing I would like to point out that in the management, since there are several things which are coming up while the patients are crossing over to the adult age group, like you very rightly mentioned, the pulmonary hypertension, pediatrician managing a pulmonary hypertension in a thalassemic who is 25 years old. I mean, that's not his or her cup of tea. You need to have, and it's not that anybody who is a cardiologist can manage that pulmonary hypertension. It's a thalassemia is a very specific condition where all the body organs are affected by one or the other complication. So there is a need to get the medicine people, physicians involved in the care of thalassemia patients, for coordinating with the cardiologist, for, and look at this, the pregnancy, whether this needs to be delivered normally. It's not just the conception that has occurred because of with some difficulties. There's cardiac problem. The anemia is there. There are thrombotic issues. So all these has to be taken into account. So gynae people have to be on board looking after the adult thalassemia patients. And similarly, the cardiology, the neurologist also, there are problems these days. And of course, oncologists have to be there whenever the problems occur with the cancer occurs in these patients. So the people looking after the thalassemia, it was pointed out that the services for thalassemia are fragmented. Rest, they are in the large cities, metros and other large cities, they are very well there, but otherwise you get cases who are for 10 years, they are getting hemoglobin of, say, they are living at hemoglobin of 6, 7, and even lower than that, and then approaching us. But Dr. Rajat pointed out, asked about what is happening to their the earning. Let me tell you that there are certain patients who are having their own practices. They are one of our patient is, she's about 42 years and she's MA LLB. She's doing a wonderful practice in the city of Delhi as well as in Pune. There are some of our patients who have gone on to join MBBS in All India Institute of Medical Sciences. So these patients who are going on to the adult age group, they are having productive life, and they are having their own they are sustaining themselves. So this is the brief comment I wanted to make. Thank you.
Thank you, sir. It's always a pleasure to listen to you, and you are a teacher, and whatever we know, it's because of you, Sopti ma'am, Mamta ma'am, that we know whatever we know about thalassemia. So just to add to what you said, we actually had a patient about 10 years old who was admitted to ICU with altered sensorium, and there was persistent metabolic acidosis. We ruled out all the causes. Ultimately, it was like query deferoxyrox toxicity and RTA-like picture, and we withheld the drug, and the child got better. So yes, that is something that one patient I've seen. Probably, I think this is what happened. Bone disease, I will definitely look up the ulnar deviation. I haven't had a look at it. And as you said, sir, we need to develop transition care. We need to have adult physicians involved in the care along with us pediatricians. And I think today's seminar would help us do that. Thank you, Dr. Agarwal, for that. And sir, as far as my experience goes, every time, the first time a patient got pregnant, then hepatitis C happened or something happens, I have to pull out literature and go and tell them, no, this is treatable, this is how you do it. Please read it. So you have to pull out a lot of literature and go to the concerned, speciality and actually push them, ki, please kar do. That's how it goes with us. I think you may be feeling the same thing.
Shruti, it took me 4 years to convince my medicine department team that thalassemia, adult thalassemics need a specific care, and you please look after them.
Yes, definitely.
Thank you so much, ma'am. Thank you, sir. Dr. Mamta, ma'am, your question, please.
Yeah, so more than a question, I'm just going to make a comment. One thing is that we are all coming of age as far as managing thalassemics is concerned, because we have been good with managing our pediatric patients. So we are now going to hand over more and more adult thalassemics to our adult colleagues. And I'm sure they will take over soon, because we are creating those in our guidelines to transition of care. Other thing which I wanted to respond to, Urmimala, who said that there is hardly any support for these patients. So I think advocacy with governments locally helps a lot. With government of Maharashtra, we have transfusions free of charge for all thalassemia patients wherever they are receiving. They get chelation free of cost. Now the prenatal diagnosis, they have tied up with our center, and they refer all their patients from various districts also to us for prenatal diagnosis for a second pregnancy. So far, primary prevention is not yet so much in vogue, except 2 out of the 103 that we have tested were primary, otherwise all are secondary. So I think advocacy at a level between institutes, between thalassemia societies and the government locally would help in a big way to get through to these problems. Second, about a question was raised about whether anybody has studied quality of life. So one of my students did a dissertation in 100 thalassemic patients looking at various domains. And to tell you very frankly, the p-value for difference between controls and thalassemia patients in every domain, social, emotional, school, playing, everything, was 0.0000. It was so highly significantly different, and lower scores were obtained by the thalassemia patients. And therefore, there is a lot of impact on the quality of life, lot of impact on the psyche of these patients, which needs to be addressed. Of course, counseling from time to time, getting a psychiatrist to help. We have had patients with depression whom we have treated with antidepressants in our center, and they've done well. And there have been suicidal tendencies among some of the patients because of their body image, their quality of life, their non-acceptance amongst peers. I think that's what I mean when I'm saying we're coming of age. There are a lot of newer issues coming up today because they are growing up to be adults and going out in the world to contest with other human beings who are normal according to them. So, and employment is a big issue. But today, again, the RPWD Act of Government of India has made it possible to give them equal opportunity, though not reservation for employment, but even equal opportunity is quite a great step in that direction. And I'm sure soon we will be able to get them little privilege in employment too, because they are not given the same type of status as normal human beings. I think with these comments, I hand over back to Amit. Thank you.
Thank you so much, ma'am. We have one question coming up. Dr. Kunal wants to know, in a case of TDT as well as NTDT with unplanned pregnancy having cardiac dysfunction, how do you manage this case actually, and how do you follow up in the due course of pregnancy?
Right. Thank you, Dr. Kunal, for that question. See, as far as unplanned pregnancy with cardiac dysfunction is concerned, your impetus should be on planning upfront rather than having an unplanned pregnancy. It would be a better scenario to intensify chelation and bring the cardiac dysfunction under control, and then have the pregnancy. But in case, such things will happen, it will have to be a very close coordination with the cardiologist, all the anti-failure medications and all that. I haven't managed it. Thankfully, I didn't have the, chance to do it like that. But in a patient with TDT or NTDT, as far as the management during pregnancy is concerned, we need to understand there has to be a pre-pregnancy step. When we are planning, we look at all the organ functions, we look at all the endocrine disorders, we supplement folic acid, we go through the drug chart, you stop hydroxyurea, bisphosphonates, or, other drugs that the patient is taking, give folic acid, the 5 mg milligrams per day folic acid to prevent neural tube defects. So all that has to be done upfront. In case the patient is, going for now, we had a couple of transfusion dependent thalassemia patients who married each other and then they went for a sperm donor. So it is important to test the donor in such a situation for thalassemia trait. So all that basic workup has to be done. And then once the, you decide and the patient conceives, then it has to be a, tightly regulated follow-up. HB has to be maintained 10. The chelation has to be withheld till the second trimester. Monitor ferritin. Monthly echos were being done. During the second trimester, we did fructosamine levels because HbA1c is unreliable in our patients with transfusion-dependent thalassemia. And, calcium, vitamin D supplementation. So these are the usual things that have to be done in a tightly regulated manner. Watch for the fetal growth, your regular scans for the fetal development, and beyond 28 weeks of pregnancy, every 2 weeks they're seen by our, combined team of cardiologists, endocrinologists, obstetrician, and ourselves. Right now, we didn't have a transition care when these pregnancies, happened. So that's how we have a, fortnightly meeting and see what needs to be done. One of the pregnancies, I remember at about 29 to 30 weeks, there was some fetal IUGR. So the patient was put on bed rest with some IV fluid. There was some reduced liquor, I remember. So with bed rest and everything, it settled. As far as anticoagulation is concerned, patients with, there is a recommendation by the RCOG 2007 guidelines where anticoagulation is recommended for about 2 weeks post normal delivery and 6 weeks post cesarean in patients with NTDT. Especially in patients who are at high risk of, thrombosis. That was a, rider there that it has to be high risk. So the first patient, I tell you, we did everything, we considered the patient high risk and we did anticoagulation for 6 weeks. If the ferritin is rising or the cardiac dysfunction is there, then second trimester onwards, you can start desferrioxamine infusion, but not during the first trimester. That needs to be remembered.
Thank you so much, ma'am. Dr. Ashok Meshram, your question, please.
Thank you very much, ma'am, for excellent presentation. So my question is regarding a clinical situation like a 30-year-old lady with on a maximum dose of a deferasirox, 30 milligram per kg, and ferritin in between 2 to 3,000. And develops rise in bilirubin and transaminitis in a range of 3 to 5 times higher range of a normal. She is non-obese and we rule out viral hepatitis. Fibroscan is normal. In such a situation, what to do? Whether to stop a deferasirox or to reduce the dose?
So deferasirox dose has to be modified. If you look at, some of the literature up to 200, we can still go with, between 200 to 400, we can reduce the dose by half. Beyond 400, we have to stop it. See, if the thalassemia, it could be because of the rise in transaminases, could be because of, increased liver iron per se. So we need to slowly, taper it and see if the OTPTs settle. If they still remain the same, then I would very, carefully just increase the dosages by 5 mg per kg. There are a couple of patients who will not tolerate that. So you have to put them on a combination or put them on desferrioxamine for some time and then gradually introduce deferasirox in a, phased manner. So it will have to be individualized and you'll have to probably redo the scenario. But remember, you've ruled out viral hepatitis, but it could be iron overload per se. Sometimes the bilirubin is rising because of increased hemolysis. Have a look at the Coombs test, antibody panel. Some of our patients continue to have high unconjugated hyperbilirubinemia, very high bilirubin levels. They were found to have Gilbert's, but of course OTPTs would be normal in such patients. So it will be a tightrope, gradually come down, go up by 5 mg per kg every 2 to 3 weeks, and then see how you can take it. You can do some combination therapy for some time, few weeks, and then then go up so that the iron levels are also under control. I would also like to look at the liver iron concentration in this female to see what is the status of the liver iron overload, whether the increase in OTPT is because of liver per se, I mean the iron overload per se, rather than the chelator.
Thank you. Thank you very much, ma'am. One more question is, how do you foresee the role of newer drugs like luspatercept in particularly thalassemia in reducing the transfusion requirement or decreasing complications?
So luspatercept, the BELIEF trial had come up recently. I think we had a talk by Dr. MB Agarwal sometime earlier. I remember that there is a role, there is a definitive role, there is reduction in transfusion requirement by about 33 patients in patients with transfusion-dependent thalassemia. Hopefully, luspatercept would be released in India by sometime next year. I think right now my biggest question about luspatercept is what is the cost going to be? Because if it's very expensive, then there's no point talking about efficacy if our patients cannot take it, right? And under the guidance of Dr. Jagdish Chandra, we are currently, there's a multi-centric trial in patients older than 12 years on thalidomide going across 4 centers in the country, which is like probably a poor man's luspatercept. So we'll have the results by the interim results by early next year. Probably that will give us some answers about the safety and efficacy of thalidomide alone, single drug in patients with transfusion-dependent thalassemia.
Thank you. Thank you very much, ma'am.
Thank you, ma'am. Dr. Gopinathan, your question, please.
Sir, with increasing patient numbers on dual anticoagulation these days, like on desferazorox as well as desferal injections, how common do you see mucor infections in them against the background of hyperferritinemia? So is it so common? Because recently we encountered one child with mucor actually. So how common is it in your practice? What are your experiences? I just wanted to take
So
that.
I have not seen even a single mucor in thalassemia in my lifetime, right?
Yeah.
The only fungal infection that I saw was about 10 years back, a child who was posted for transplant and had I vaguely remember had some, high iron overload. So the plan was to put the patient on desferrioxamine infusion for a intensive chelation for a month's time and then take up for transplant. Now I'm talking about 10 years back, not today, right? And within that 1 month, child had actually developed a palatal perforation, sudden. And one of those days in the OPD, we saw a child had palatal perforation, and that child had aspergillus. I mean, the culture had, and the fungal material that was aspirated had actually shown aspergillus. That's the only time I remember I have seen fungus. Otherwise, I've not seen any fungal infection in patients on desferrioxamine. One patient, this is actually mentioned in patients who actually died of infection, was actually employed in the dairy business. He had his own dairy farm and was dealing with cows and dairy animals. And he had developed a very funny brain lesion. The patient was on desferrioxamine, and he came with features of fever with raised ICP. And the MRI had shown a lesion. We could not biopsy it because the patient had actually herniated within a couple of hours of admission, and the parents did not agree for a biopsy. But that's something I don't know what it was, but that's something which is, back of your mind, keeps troubling you. I would have liked to know if there was something from that, relation with the dairy business. There was some atypical organisms, but that's remained a mystery for us actually.
Our child also had a similar presentation like what you're describing it right now, ma'am. He came with fever and he came with raised ICP signs, and then he had brainstem signs like ataxia, all this labored breathing and all, and he had multiple cutaneous nodules also. So it was the biopsy of the skin lesion which clinched the diagnosis. It was mucor. Actually, he was on dual antichylation, and unfortunately, it was a very painful learning experience for us. He went in for invasive ventilation, and ultimately, we have to lose him. Actually, so it turned out to be mucor. We still, though we managed with liposomal amphoby, and we tried to do as much supportive care as possible, but we unfortunately lost him. So that's what should be. Is it so common across centers, or it is very one among? It's a rare scenario.
I believe it's a rare scenario. I think Mamta ma'am is nodding, so I believe she agrees with me. Well, we've not really seen her. I've not even, because when I was searching literature also, I didn't find any literature as such on mucal. With desferrioxamine, what we see is a lot of gram-negative sepsis is what we have seen, but not fungal.
So while taking this high-risk thalassemia patients for transplant, so do we, apart from HRCT, then are we justified in getting any other serological tests for ruling out this IFA? Is it a common practice that we employ?
So I don't do transplants, but I don't think as a routine, it will be done. Of course, you'll do a CT to rule out, but not serology. Mamta ma'am can probably, or, I think I saw Ruchira and Shantanu, our transplant colleagues, can probably make a comment on that.
So we don't routinely do any further testing except HRCT.
So here we
Thank
go.
you.
Thank you, sir. And ma'am, Dr. Vinayak Chikodia says a question: how common do you get acquired elastography in thalassemics? Fibrosis.
Fibro, actually, frankly telling you, Dr. Amit, we have a radiologist who's trained in abdominal radiology, and he's apparently very good. So we've been following up all our patients with ultrasounds on a 6-monthly basis. Fibroscan, it's mainly the cost issue, so we've not been doing, but the recommendations are there to monitor every month, every year for patients who've had a history of hepatitis C or have high iron overload. So we just, modified it to suit because, we had the availability of an expert abdominal radiologist. So we just stick to ultrasounds routinely by the same person, not change over, So that's how we are doing it. But recommendations say 1 year in high risk patients. And I think I just read about this December issue of Indian Pediatrics. There's a paper by Dr. Chandra which has actually shown correlation between ferritin MRI and transient elastography, and he's shown how you can use fibroscans to follow up, and it will predict the it correlates with MRI. Actually, if the MRI is worsening, the TE will also worsen. So if MRI is not available, maybe that may be used, but I don't know how often TE is available at other centers and whether it would be easier to replace MRI by elastography. We need some literature on that.
Our guidelines will remain the same. First, ultrasonography. If ultrasonography shows a defect, then alpha fetoprotein and fibroscan. We are not doing alpha fetoprotein routinely also. Dr. Amit Jain, your question, please.
So, ma'am, your experience on renal complications in thalassemia. So actually my dissertation topic was renal dysfunction in thalassemia, in which all the children were well managed, means maintaining adequate pre-transfusion hemoglobin, no clinical signs or imaging finding on sonography regarding renal dysfunction. So what we found out that around 54% of the patient had hyperfiltration on DTPA scan. Otherwise, no significant findings. So ma'am, your comment on that.
So Amit, renal is something I've been, trying to do for a couple of years now. We want to, kind of do a study. We're trying to raise funds for that. But over a period of, last 10 years, serum creatinine creatinine values have not really bothered as such, even if in patients in which, serum creatinine goes up, there are sometimes, other reasons like diarrhea, dehydration, you correct them, the serum creatinine settles. And in case there is a rise, you hold the drug, withdraw, reduce the dosages, it settles. So it hasn't really bothered us. So that's how probably we don't have that impetus to really go for it. So been just playing with that idea of doing that study. But as you said, we can do a DTPA scan, but clinically how useful all these parameters are, again, long-term studies can tell us. My only issue was, when I told what I told Dr. Chandra, that child with and DFX toxicity, query DFX toxicity, because we didn't find any other cause. Severe metabolic acidosis, not responding to anything. Thankfully, the child is now okay. The other, recently one child, baseline creatinine was like 0.8, developed dengue and dehydration and came back with creatinine within 15 days of having a baseline normal serum creatinine. On deferasirox, came back with creatinine of 5.8. And just 2 days he had history of dengue, NS1 positive, high grade fever. One night prior to admission, he had 11 episodes of loose stool. So it was too early, too sudden to cause a creatinine of 6. So that's something which we are trying to explore if there is anything else he's taken. But we just looking at that child, but it's non-oliguric and it's actually day 4 of admission, and the creatinine is slowly, it was 5.8 at admission, it was 5.1 today. So we need to follow up this child and see what happens.
Thank you. Thank you so much.
Thank you.
One last question, because we are just running short of time. 1 minute left. Dr. Gopinathan, your question, please. One quick question, please.
Yeah, ma'am. Just what are the ready for the big transplanters who are in the early part of their career? What are the red herring signs that you give for before taking an older child for allogenic transplant with thalassemia major? Up to 18 years is what textbook says. What are the red herring signs between even more than transplanting more than 7 years is a bit challenging in our setup, to be frank. So in these cases, what are the red herring signs that you give for beginners actually?
So I think I can see Mamta ma'am smiling. 18 years, we would be a little concerned transplanting beyond the first decade. 7 years. Red signs, as you said, plaque signs would be a high ferritin, hepatosplenomegaly, which is there. Look at the antibody screen. If the patient has any, antibodies, there may be some issues during the transplant. But, something that I would like to say, a lot of times, when patients go for transplant, neither the transplant center nor the patient comes to us and asks for a summary. They just go get a transplant done as if, sometimes I tell whenever I meet on another platform, I tell the transplant physicians, why don't you ask me for a summary? You will get to know the details, if there was any liver issue, any kidney issue. So I think that's what I would like to, put across, that if you're getting a patient from another center for a transplant, do ask for a summary. There may be some minute details that, I would love to share it if the patient is going for a transplant. So get a past history, get a summary, look at the liver iron overload and cardiac dysfunction. And beyond 10, it has to be I would think of avoiding a transplant beyond 10, because as a lot of us are discussing, our patients are not that well managed. Till 10 years, they've not taken transfusion properly, chelation properly. And suddenly, because the government is giving 10 lakh rupees, we're doing a transplant, doesn't really make a sense. You need to optimize the patient first, put them on regular transfusion, bring down the iron levels, and then probably give it 6 months to 1 year. Don't be in a hurry to just take up for transplant.
So if I can just give a quick comment. So I think Dr. Gopinathan, you will have to look at the status of the cardiac pulmonary hypertension related. You'll have to evaluate the liver in detail, any fibrosis, the hepatomegaly. Even without hepatomegaly, you will have to worry about fibrosis and cirrhosis. I think only Dr. Mahaman Chandi can give us answers what you would not transplant after 18, because he's the one I know who has transplanted 23, 24-year-olds.
Yeah.
Most of us, we do not venture in any patient who's about 10 years. At least at our center, we don't take about 10, 11 years. But Shantanu and Ruchira could have added more light to this. They are not seen on the screen. Otherwise, you can personally talk to them also.
Thank you, ma'am. Thank you, ma'am. Thanks a lot.
Thank you so much, ma'am. Thank you, Shruti ma'am, for that wonderful lecture and wonderful question answer session. I hand over the dais to Mr. Sumit Madan from Zydus for final vote of thanks.
Thank you, Dr. Shruti Kakkar, for sparing your valuable time on this Sunday. It was a lucid presentation, and we had many key takeaways from this wonderful presentation. Our heartfelt thanks to Dr. Amit Khurana for navigating the entire webinar in a highly proficient way. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal sir, for providing us this opportunity and making us a part of this elite academic discussion. I'm sure all the cases he presented today would be very, very insightful for many budding clinicians. I also thank the chief guest for today, Dr. Mamta Manglani, all the discussants and participants who have joined us for this webinar. Last but not the least, this webinar would not have been possible without relentless support from Perfect Sphere Group. Thank you, everybody. Have a lovely weekend.
Thanks, Sumit, to you for supporting our activities. And thanks to Zydus in general. Thank you.
Thank you, sir.